And as Lillian said earlier on, it is our responsibility as an organisation to respond to your needs. There's no point in us telling you what you think you want when you actually tell us what you want. And that's done through collaboration and through communication. And we are very lucky in this country that we have got wonderful hospital services that when you do access them, you're led by a team of excellent professionals, and we have them right around the country. And I'm delighted to say we have one of the most preeminent scholars and the preeminent physicians in the world dealing with this illness based in Ireland. When we raise funds to support you guys on your journey. But we also give to research, and that's very, very important. But we couldn't kind of fund all the research that's needed there. So we're lucky insofar as not only she is a brilliant physician, not only is she a brilliant scholar, she's also really good at fundraising as well. So we can fundraise to try and find a way through motor neuron disease so that future generations won't find themselves in rooms like this talking about this condition. But to give us an update on research and where the world is at, would you please welcome to the stage from Trinity College Dublin and Beaumont Hospital, Professor Orla Hardiman.
Thanks very much, Jonathan. So this is a time for optimism. We're not quite there yet, but I have to say that I've been around a long time, and over the past maybe 3 or 4 years, the whole field has changed in terms of how we're thinking about motor neuron disease and the sorts of innovations and research that will lead to improvements in clinical care and ultimately treatments has changed to a point where we should really be very optimistic. So that's what I'm going to talk about. So also, as Jonathan said, we're lucky because we train very talented people in Ireland, and in my day we all emigrated. But nowadays we can both train people and retain people. And because of that, we are now recognised in Ireland as one of the leading clinical and research hubs for motor neuron disease in the world. And I actually edit the journal for motor neuron disease. It's called ALS and FTD, or ALS and the frontotemporal degenerations. And I've been the editor for that journal for quite a long time now. But we're very much on the map from a European point of view. In Trinity, I'm going to have to face this because I think I probably need new glasses. I should have gone to Specsavers. If I look up or look down. So in Trinity we have over, actually probably 50 is an underestimate now because I forgot about the data scientists, but we have probably about 50 clinicians, and some of them are here today, so are some of our Miranda people. Are the Miranda people in the audience? They're in the back at the booth. Are the Miranda people? No? They're hiding. We have some people, at the back? Outside. So she's been here listening to me. So we have 5 clinician scientists that are funded by the Health Research Board whom we're training to do research in motor neuron disease. But we have lots of other researchers spanning from trying to find new drugs all the way through to some of the work that Naomi is going to talk about around health services research. And then linking in with people in the Centre for Mathematics and Computer Science and Data Science in Trinity called the ADAPT Centre, where there's about another 40 people working. So we do world-class science, and we've put through about 20 PhDs or more in the past 10 years. Over my career, I've put that through about 32, and they've all been in motor neuron disease. And our research is cross-disciplinary. We've made a big point about being very clinically oriented, so we don't do animals. I actually formed the opinion very early on that there are lots of people who make their career studying models of the disease in animals, and that's very important scientifically. But there's no doubt that motor neuron disease is actually a human disease, and however good our models are in animals, in mice, and we've worms and we've flies, and we've rats, and they never recapitulate the disease that we see in humans. And the best way to study motor neuron disease in a human disease is in humans. The trouble is that the technologies that we have to study this disease in humans still aren't really up to the level of sophistication that that we'd like them to be. So we still work with our basic science colleagues to try and understand some of the cellular pathways that are involved, some of what happens within the cells that make the disease, make the neuron sick and start giving trouble. But we very deliberately focus very early on to say, okay, we're going to study the disease in humans. We're going to do as much as we can to improve how we study this condition in humans, using and harnessing new technologies, including lots of mathematics and engineering statistics, but particularly neural engineering, ways of understanding the brain, looking at electrical signaling, and then working with our mathematics, statistical and computer colleagues to really harness some of the technologies around artificial intelligence. So we've positioned ourselves very much and unapologetically, and we are a world leader in all of these areas. And then we work closely with other groups. So, for example, the College of Surgeons is a group led by my colleague Joachim Pren, who does basic science, and that's really important, and it can help us to understand the disease and to help to identify new treatments. But we still have to be able to understand the disease in humans to make sure that a treatment that might work in a cell, in a plate of cells, or in a mouse, that would be likely to work in humans as well. So this is Mark Heverin. Some people may have met Mark. Mark is our research manager and has been working with me for over 10 or 12 years now. And he coordinates all of this research work. But just to give you some examples, and IMNDA is helping to support some of these people as well. So, for example, Beaumont Nasser Sami, who's a neural engineer, he's permanent in Trinity now, so he has a very large group of his own, about 20 people. But Beaumont was funded by a fundraising that Father Tony Coote generated, the Walk While You Can. And he raised €250,000, and we were able to match that with another philanthropist, and we were able to fund Beaumont for the first 5 years of his career in Trinity, and Trinity has taken over his salary now. So Beaumont is a permanent fixture now in Trinity, and is dedicated his life to understanding the electrical signaling in motor neuron disease. So, and he's trained a load of new people, including a very bright girl called Lara McManus, who's just won every single grant that you could possibly win, including a very prestigious award in the UK called the Royal Society. And she's going to be working with us now and will stay with us in the longer term. And another girl called Roisin McMacken, whom some of you may have met, who's also trained at Beaumont as a neural engineer, is now permanent in Trinity as well, and is dedicating her life to understanding this disease as well. So these are our international figures. Some people know Miriam as well. Oh, sorry. So Miriam is actually supported by IMNDA. And she's a research methodologist, and she keeps us all very honest. She's interested in health services, and she's interested in the patient journey, what's happening to the person as they experience their condition, and particularly the person within the sort of healthcare ecosystem, and the person and the caregiver, and the impact that the condition is having on the entire experience that the person has. And we're very grateful to IMNDA because Miriam is a really important part of our research, a member of our research group, and wouldn't be in post if it weren't for a grant that we've obtained over the years, recurrent, from IMNDA. So we're really grateful to IMNDA for the support for Miriam. She's an associate professor now. Niall Pender, some people know as well. Niall has just joined us in Trinity. He's a neuropsychologist, so he's been driving all of the work that we have been doing in the problems that are associated with motor neuron disease around thinking and behaviour. Peter, some people know. I think Peter is or was the patron of IMNDA, still is. And Peter, I was talking to Peter this morning. Peter is Hungarian originally, so we got Peter around 2011. He did his PhD with us, and he's interested in brain imaging. And Peter is now a world leader in brain imaging in motor neuron disease, and leading out on quite a few very large projects. And I have to shackle him when he goes away, actually, because people keep on trying to poach him to go to other countries. So I have to have a chaperone with him every time he goes away to a conference, because somebody will try and give him a job. Russell McLaughlin is our geneticist, and Russell is also permanent now. He was funded in the past by IMNDA, but also MND UK. And then the two girls here, Dara Meldrum and Deirdre Murray, and Dara and Deirdre, along with Miriam, are running the Miranda project. This is the project that I mentioned at the beginning, and they're both academic physiotherapists, but they're leading out on quite a lot of research around how do we measure the disease progression, and are there better technologies that we can use to measure these. So that's That's the leaders in the research group, but there's about, as I said, 50 or so in that research group. We also have a clinical trials group that's separate, that's based in Beaumont. That's a small proportion of the clinical team, very out of focus as well. Sorry about that. But in Beaumont we have expert clinical staff as well, and the clinic is a clinic that provides service, but the clinic, like all clinics for rare diseases, has a role in trying to understand the disease as well. So the clinic is embedded into the research, and the research is embedded into the clinic as well. And the clinic has an international reputation as well. We're known for the services that we provide. We're often asked to advise on setting up these types of clinics. We run the register, the Irish Motor Neuron Disease Register, through the clinic as well. I'll show you some evidence in a few minutes that how valuable this expert team of within the clinic is. I was going to say something else I forgot. So what of our objective? Our objective is to understand the cause of motor neuron disease to the extent that we can develop new and more effective treatments and provide evidence-based care for all those living with the condition. So our work is it's iterative, it's continuously learning. What I was going to say actually about the clinic is that we're also part of something called the European Reference Network. So you have to apply for that and you get audited. And so they looked at all of the data that we provided, and we're full members of the ERN. That means that we have to accept people from other parts of Europe where if they need an expert opinion, we'll take them. So we've seen people from all over Europe as well. They haven't been able to access care or services or expert opinion from their own countries. And that's a job that we take very seriously. So what about the current state of the art? Well, we know a lot of the work that's been done over the last few years is that what is elucidating what we don't know. So we used to think motor neuron disease is a disorder of motor nerves. The motor nerves die, and if we could fix the motor nerves from dying, we'd be able to fix the disease. And unfortunately, the very early research in the 1990s, after the first gene for motor neuron disease was identified, was called SOD1, kind of reinforced that idea, because that abnormal gene was put into mice then, and that abnormal gene causes a pure motor neuron disease in mice. And so lots and lots and lots of research went into trying to cure the mice, and some of it quite successful. The trouble is that over the last 10 years or so, the differences between the SOD1 mouse and the human disease have become really apparent. And most of us now believe that it's an interesting model, but it has a limited benefit in trying to understand the complexity of the disease in humans. We had a debate a few years ago. I'm chair of the European Network for ALS. We ran the meeting in Dublin a few years ago. We debated saying that the SOD1 mouse has outlived its sell-by date, which is true actually. But all the basic scientists wouldn't agree with us because they were getting grants, and all the clinicians were saying, well, you know, it's just a much more complicated disease. So I think most people accept that it's a lot more complicated than we originally thought, but this is the model that we're working on now. So we think that it's a complicated disease where there's a genetic effect, and I'll show you some data with that, and then there's something that happens during life. So this is epidemiology and more genetics, and exposures, and then there's a bit of time, and then there's no evidence of disease, but it may be cooking in the nervous system, and then something happens and the disease starts to progress. So trying to understand that model then and break it down into different components is what we're trying to do. And that's really complicated because the other thing we know is that it's probably more than one disease. So genetic effects said some other things that happen, and then the cascade of the disease. So here's some work on genetics. So we know that this is from our register. So we have a population-based register, and I think everybody here has been asked would they be okay if we put their information on our register. We've been running the register for 29 years now, so we have really good data about motor neuron disease in Ireland, and we've been following. People have been very generous in allowing us to follow them, and we can show now using both epidemiology but also genetics the proportion of motor neuron disease that is probably accounted for by our complement of genes, so that's called heritability, what you inherit from your parents. And I'm using some mathematicians by Marie Ryan, who did a PhD with us. About 51% of risk is stuff that we inherited from our parents. So that's not really that unusual. I mean, that's true for lots of conditions. You know, we have a tendency towards certain things, a tendency towards asthma or a tendency towards migraine. It doesn't mean it's a single gene. It means that lots of genes that we inherited from both our parents might slightly increase the risk of us developing something. And if we look at this mathematically, we can show that that accounts for 51%. The other 49%, we're not quite sure. Some of the work that Marie did as well was really interesting because there are gender differences as well. We know that motor neuron disease is a bit commoner in men. But if we look at familial motor neuron disease, and this is mathematics, it's population level, there's a higher rate of transmission in familial disease if it's coming from the mother. And that's telling us something about the genetics as well. We haven't worked out what that's about, but there is a gender effect as well. There's a guy working with Russell McLaughlin called Ross Byrne who's been working a lot on this in the recent past. So genetics account for about 50% of the risk of developing motor neuron disease. So what are the genes? Well, we know there are some big genes, and we know that it is motor neuron disease in the family, it may be due to one of these big genes that has more than just a little effect. It may have a big effect. So there's about 40 genes been identified, but realistically, there's only really 4 that are important. So these are SOD1, which is the first one. The size of the gene actually is incorrect, so that bubble is far too big, especially in Ireland, because SOD1, we've nobody that we identified one person in the south with SOD1 back 20 years ago. So it's a very rare gene in Ireland. There's a family in Northern Ireland, but not in the south. Then the other genes, TDP43, we have a couple of people, not that many. FUS, we have 2 families that we know of in Ireland with us. But C9orf72, this gene accounts for about 10% of motor neuron disease in Ireland, and about 50% of people where it's in the family. And of the other people, we don't know what it is. So one of the things that we need to think about here is that these are lots of genes. Most of the heritability, we don't know what it is yet. And we need to work on that to try and understand that, because what we want to do is take what's called a precision medicine approach. A precision medicine refers to the tailoring of medical treatment to the individual characteristics of each patient. So cancer has been very good at doing this. Cancer is really a precision medicine treatment paradigm now. We're a little bit further away than that in motor neuron disease because we don't have the technologies to measure the disease such as could be done within cancer. But that doesn't mean we won't be able to do it in the future. So one of the things we get often asked about is, okay, so we know there's a genetic risk. What about environmental? Are there things, and we often get asked, so I live in a village in the middle of Ireland, and there are 4 people in my village who've had motor neuron disease in the last 10 years. Is that a cluster? Is there more motor neuron disease in my area than there should be, because I know lots of people, or I know people who know lots of people? And so we looked at this. This is James Rooney. He did his PhD with us a few years ago, and he started looking at, are there environmental risks? And actually, we haven't been able to find any at all. We did a number of studies. James did a clustering study in Ireland, and we also were a part of this group called the Euromotor study a few years ago, trying to look at environmental factors. And then we looked at this in South America as well. It's the Lane-Al study, it's called. And then James is doing another study called MET-ALS, where he's looking at heavy metals. The trouble is that these are very hard to detect because this is a rare disease. We need very large numbers and combinations of different types of data. So we haven't really found any definitive environmental exposures. There are some papers that suggest maybe exposure to pesticides from the US. There's a guy called Wally Bradley in Florida who's convinced that it's from algae blooms, so people living near water. But I'm not sure I believe any of those data. There's a lot of flaws in the data. So my view is that there may be environmental exposures. Part of the problem is that if there are gene-environment interactions, you might have to have a certain genetic complement for the environmental exposure to have that effect. And that's one of the problems that's very difficult to do that without very large numbers. So at the moment, we don't have an answer about what the environmental exposures are, and they may be different for different groups of people, or there may be a gene-environment interaction. So we need to go back to look at, okay, so what are the complements of genes that might be important that might make the disease generate risk that would then interact with some environmental exposures. So what can we learn from the genes? Well, as I said, we know that this gene, C9orf72, accounts for about 50% of known familials, about 40% in Ireland actually. It's probably a Northern European gene. There's some evidence that it's from up sort of the Rus area, which is sort of kind of a bit where Ukraine is now, and up going into Finland, and then came down across with the Vikings. So it's very rare in Asia, and actually quite rare in Latin America as well, but not uncommon in Europe. So there are population differences as well. So we looked at the rate of the rate of familial disease in Ireland. So we know CNNF accounts for a certain proportion, and we know that familial motor neuron disease is present in Ireland, but to what extent? So this is also Susan's work, and in Ireland we've shown that up to 20% of people have another family member with motor neuron disease or frontotemporal dementia, because that's linked as well. Motor neuron disease and this type of dementia are related to one another, so we sometimes see a little bit more of this type of dementia where personality change in family members of people with motor neuron disease. And of these, 50% carry this CNNF72 gene. One of the things that we were looking at as well, and this is something that that's interested me for a very long time, is because it's a scientific question, that okay, if there's motor neuron disease in the family, are there other conditions running in the family that might give us a clue as to what the genetic basis for this is? So Susan did some work on this, and then Margaret O'Brien, who some people know, she's my colleague in Beaumont, did some work on this as well, and Marie Ryan as well, looked at, so are there other conditions that run with motor neuron disease within families? And we found actually that there were, and this is really interesting. So, and not neurogenital disease, which is kind of weird. There were more people. Some families with motor neuron disease have a little bit more other brain disorders, which would be seen by psychiatrists, but they're still brain disorders, things like bipolar affective disorder or schizophrenia, or next generation autism or ADHD. Now that's, I mean, these are common conditions in the community, and every family probably has, if we look hard enough, we'll find, you know, these sorts of problems are very common. But a little bit higher rate in those with families with motor neuron disease. And that's telling us something about the risk, the causes, the genetic factors that might make this more, people more susceptible. And so we also looked at what we call superfamilies, looking at genetics and trying to identify people that might know that they're related to each other, and showing a little bit higher rates of these conditions as well. So if we study family members with MND, we've shown that there may be a link between ALS and motor neuron disease and some other, what we would generally call neurological or neuropsychiatric disorders. And this is probably genetic. It's probably about brain development, and it may be that the clue there is that the genetic risk is mediated by how our brains develop, and so it may be a developmental risk that the brain is connecting with itself in a particular way, and that makes it a little bit more at risk for whatever exposure happens later on. So that brings us to the work that Beaumont is doing. So understanding these links will help us to find better treatments. So what other ways might we do this? So this is Peter's work. So Peter has been doing brain imaging and showing different parts of the brain, showing really that motor neuron disease isn't just a disorder of motor neurons, that there are other parts of the brain that can be affected as well, and also showing that the C9orf related motor neuron disease behaves a little bit differently from the people who don't carry the C9orf. So Peter has continued to work in that area. This is Beaumont's work then, so we're very interested in patterns of the brain. So some people have very kindly participated in our studies looking at brainwave activity. And so this Beaumont and Roisin McMacken as well has been doing this work, and Lara McManus that I mentioned. So looking at different patterns in how the brain talks to itself. And we can show that there are different patterns between people with motor neuron disease and people without. And we can also show that if you look at the brain patterns of people with motor neuron disease, or ALS, we use the terms indistinguishably, you can cluster those into different groups, and the types of changes that happen in the network differ between different groups, and that may be something that we could use in a harness to determine whether a drug is working or not. So this is really exciting work, and we are very much the leaders in this field in brain networking. So this is some of the work that Roisin and another of Beaumont's PhD students, whom we've now lent to the Netherlands, so they're replicating all of our work in the Netherlands and in Utrecht. So Stefan has moved over to the Netherlands and is sort of spreading the gospel of these brain networks and showing these changes in brain activity. And we're also doing these activation things where we can show changes in how the brain reacts to certain stimuli. This one here is a beep, 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 boop, and the brain reacts to the boop, and then we can show differences in people with motor neuron disease and people who don't. And again, that might be useful in terms of trying to understand how the networks are changing, and that in turn may help us to find ways of determining whether drugs work or not. So these are important. So finding more genes, and we're working, so I mentioned all the big genes, but what about all those little genes that are maybe confer a tiny little bit of risk, but if they're all working together, what does that mean? So we're part of a very large consortium called Project Mine, and it's coordinated out of the Netherlands, but Project Mine is looking at the whole genome. So we're doing whole genome sequencing, so everything in our chromosomes, and trying to identify, are there patterns in motor neuron disease of certain genes or certain genetic characteristics that are more common in people with motor neuron disease, and can we cluster that out? So it's a very, very big project, Project Mine, where it's about 21,000 people now, and that's ongoing as well. So there's 17 countries involved, but we're one of the first countries to participate in Project Mine. We're also, because motor neuron disease is a rare disease, where you have to work with other groups. I mean, there's 140 people who get a new diagnosis of motor neuron disease in Ireland, and it's about 450, I think, on the IMNDA books. We'd follow most people in our clinic in Beaumont. We'll talk about that in a few minutes. But it's not enough to really understand the disease. We need very large numbers, we need scale. So we're working with our colleagues across Europe. So I'm the co-chair of this group. Sorry, I've gone. The NCALS group, which is European Network for ALS. And they're the NCALS sites here. There's about 70 or 80 now, actually. But there's a smaller group called the Treatment Initiative to Cure ALS, the TRICALS group. So I'm got the co-chair of that as well, and that's a smaller group of centres that are just really interested in trying to build better programs for clinical trials. So we set out together a sort of roadmap of what we need to do to get better treatments into the clinic, and these are the things that we said we'd do as 5 lanes in that roadmap. So we've taken that to the next level now by harnessing the expertise across Europe, but led out of Ireland, which is great. So we've got a big grant from Science Foundation Ireland as part of their centre grants. They provide centres, they provide funding for centres. There are 2 centres involved. One of them is called the ADAPT Centre. There's a logo there it is. And the other is called Future Neuron. I'm a member of both, actually. Future Neuron and RCSI, ADAPT and Trinity. We put in a proposal to SFI with partners from industry, and we've got 11 million euro now to run Precision ALS, and here are the partners that we're working with in Europe. They're the main sites in Europe that run population-based registers, and they're all going to help us on this big Precision ALS project. And then the data science partners are to the ADAPT Centre, which is Trinity, DCU, Technological University of Maynooth. And this is what we're doing then with the data scientists. We're building a new platform to collect information. We built a new tool to collect information from people, and there's a whole load of GDPR stuff, legal stuff that we need to do to make this compliant. And then the plan will be that we'll work with our colleagues in the data and computer science so that we can use the data not only to examine things the way we normally would, but use mathematics and statistics and machine learning to understand the disease in ways that we mightn't be able to understand just by people like me. So we've got industry partners involved as well, so it's a very big project. And the objectives here are to allow us to integrate data. Multimodal means from lots of different sources, so the clinical story, maybe blood samples, DNA samples, brain wave testing, brain MRIs, genetics, lots of other, and some other technologies that we'll be using, and put them all on a big platform that can talk to itself. So we'll have clinical, the person's information, but then we might want to measure that against their brain waves, against their genetics, against their blood markers. And so you need to be able to do this at scale, so that the platform will be able to do this, so that we can then develop novel tools towards these integrations. This is mathematics and statistics, computer science, And then this is artificial intelligence, so that we can, the sum will be greater than parts. We'll be able to understand disease a bit better using modern AI type tools. So that's what it looks like. So this is the stuff we collect as clinicians. This is the disease. We collect all these things. They go into the data platform. All the analysis happens, and then we get new information that would be suitable for allowing people to understand the precision medicine approach to get the right drug to the right person in the right dose at the right time. That's our objective. So what are we doing at the moment in clinical trials? So this is a picture of the 2 clinical trial centres that we work with. This is one in Beaumont. It's a very flattering picture of Beaumont. This is our clinical trial centre. It's actually, this building belongs to the College of Surgeons. We could show you a picture of the prefabs that are sinking, but that would be very rude. And this is a shiny one that we use in St. James's Hospital for our genetic studies. So we're doing some very early gene work as well with the Clinical Research Centre at St. James's Hospital. So there's been lots of clinical trials. Actually, that's an underestimate, about 100 negative trials over the years, because people thought, oh, this drug works in a mouse, we'll just try it in humans. And that was really stupid, because the drugs didn't work in humans, because the mouse is different from humans. So it took about 15 years to actually get that, to understand that. And even now, some drug companies still want to know if the drug works in a mouse, but it's an erroneous way of looking at it. So we know that these animal-based approaches haven't been successful. We know that subgroups are likely to be the case. Precision medicine, it's like cancer, it's like pneumonia, it's like anything. You probably need to have the right drug and the right pathway. And we need better markers of the disease. In cancer, you can do a PET scan or a CAT scan, or you can take a biopsy. We need to find better ways of doing that in humans. And then we have the outcome measures, which at the moment aren't very good either. But having said all that, there's been a resurgence in interest in motor neuron disease by industry, which is fantastic. So I was on at a meeting yesterday virtually in Florida, where it's called the NEALS Group, the Northeastern ALS Consortium. I was asked to speak about precision ALS, but there was 4 presentations about some of the trials that are underway. We're doing all of those trials here as well, actually. But there was a huge sense of excitement and optimism about these new trials that are being looked at, and lots of new companies coming in, small biotech companies. Biotech companies get bought over by big companies, so huge amount of interest. And probably 20 is probably an underestimate. And there are design driven, so there are some precision medicine-based approaches already that are coming into the market. There's one already. So these are gene therapies that turn off the bad gene. So this is, they're called antisense oligonucleotides, so the gene therapy. And this one here, SOD1, the gene therapy is called tofersen, and it works. It's really impressive. So if we have somebody, which we don't in Ireland, who has an SOD1 related mutation that's causing their disease, giving tofersen will stop the disease from progressing and might even reverse it. So that's really exciting. It's a good proof of concept as well. There's a second gene, which is really rare, but we have 2 families. The gene is called FUS, and that looks like it works as well. I've seen some of the very early data. So we're doing the FUS trial in Ireland. So we've 1 young man on that at the moment, on this FUS trial. There's another trial called ataxin-2, so that makes the disease a bit worse. That's in early phase. We'll get that when it comes to the later phase. Unfortunately, the clinical trials for C9orf72 haven't been effective. We've done 2 so far, and they were stopped. So we have to go back a little bit to the drawing board for C9orf to understand why those clinical trials didn't work. What are we doing at the moment? So these are the trials that we're either have enrolled in, where we're just waiting for the report, or where we are enrolling. So we'll know about this one. This is TUDCA. This is an investigative study. We'll know about that in December. This is the ADORE study, so that's edaravone. So this is Radicot in America. In America, you have to give it by IV, and this is a tablet. So we'll know if ADORE worked in April that should be 2024, actually, sorry. Phoenix is the Amylyx compound, and it has a weird name, which I can't remember. Relivio in America, but in Canada it's called something else. It's been licensed in the US, but the EMA wouldn't license it in Europe. They didn't think the data was strong enough, and I kind of agree with them. So we're doing another trial for this Amylyx drug, and we'll know that, and that should be 2024 as well. We're doing this study here called Lighthouse. It's a drug called Triamec, which is a drug that's used for AIDS, and some of the early data looked very hopeful in that, so we're doing that study as well. And then these two studies we're enrolling at the moment. Well, actually, DAZZLES we've started enrolling. So that's an early phase compound working on the cortisone pathways. And this is working on pathways related to iron. And actually, it's not quite true. We aren't actually quite enrolling yet. We're just waiting for contracts to get finished. And then we're doing 2 early phase gene therapy studies. There's a small company called Coralis. So we've 1 patient on this, and this we've 1 patient on this. This is the first study. So lots going on, and there will be more next year as well. So the last few minutes I'm going to talk about, so that's all very well, and but we have to live in the moment as well. So we have to understand what we need to do to make sure that we provide good care for people while we're waiting for these drug trials to show whether they're effective or not, and while we try and understand disease. And one of the things that's really important is multidisciplinary clinics are really important. So the clinic in Beaumont is really important. We did a study a long time ago showing that a multidisciplinary clinic improves the outcome. This is the probability of survival. And this is a comparison between Dublin and actually between Dublin here and then the sea countries is kind of a yellowy line. This is people going to non-specialist clinic in anywhere else in Ireland. This green line is a comparison between the Beaumont Clinic and Northern Ireland, Belfast. So Belfast is interesting because they have a multidisciplinary clinic, but the care then has devolved out into the other hospitals within Belfast. So the Belfast Clinic does sort of diagnosis and a bit of sort of planning, but the ultimate decision making then happens locally. And you can see the difference. If the decision making isn't happening centrally, the outcome isn't as good. Now, we were the first to show this, but loads and loads and loads of centres have shown this now, that multidisciplinary care is better for people, it improves outcome, it's better for services, better for decision making, it's better for quality of life, and it's actually more efficient. And the Dutch showed that it's more financially beneficial. So there's no doubt about that at all. Now I'm just stepping down. I was a clinical lead for neurology for the last 4.5 years, and I was involved in designing new pathways for neurological care in Ireland. And we took motor neuron disease as an exemplar of a rare disease to show what you could do with the rare disease to improve outcome, and to show linkages with the IMNDA, with the voluntary sector, can be really beneficial. And we put together a pathway and submitted for funding. And the pathway was based on the idea of a national centre with specialist professionals, multidisciplinary team providing face-to-face video linked and home visits, keeping an eye on breathing, integrating with the community's care, integrating with the CRC, making sure that we're well integrated with the IMNDA in terms of the advice and clinical support, and equipment, really important, and then again iteratively feeding back the whole time to the special services within the hospital. And of course access to clinical trials, very important. So this is really horrible. The HSC made us draw this. They hired Price Waterhouse, so they do planning by PowerPoint. So we had to fit everything onto one PowerPoint slide, which is really annoying. But basically, this is the pathway, and I would challenge anybody to read this. But it looks really impressive. But it was funded, and so the objectives are to enhance our community outreach by our clinical professionals, increasing our home visits, enhancing the use of telemedicine, which is remote engagement where necessary. We want to improve our relationship with the CRC, the Central Remedial Clinic in Clontarf, to reduce the waiting period and improve access. They've actually come to the clinic, actually, so we need to progress that. Increase our monitoring where people are going to have breathing trouble, that we can jump on that and increase assessment of anticipated need so people don't end up coming to the emergency room. And then, of course, our nurses in Beaumont will go out and start a person on the breathing support if needs be. And then helping to integrate, working with the IMNDA, integrating the community, hospital community, and palliative care services. We also have funding now we're just about to advertise for a genetic counsellor, because of the genetic part of motor neurons. It's very important that we can give people proper advice about that. So we'll have to train somebody up to do that. And there's a lot of work going on across Europe and in the US about this, about what do we do with people who might be at risk, what do we tell them? So that's really important. It's very important that we give people access to clinical trials for these new treatments. Not everybody is suitable, but we want to increase the access for those who are suitable, and we'll continue to try and work on the suitability. And then family therapy through our social work and psychologists to make sure that we improve outcome. So now this is the HSE funded multidisciplinary team. We have 2 consultants, me and Margaret O'Brien, 2 ANPs, that's Bernie is one of us, and we have a post just open, 5 clinical nurse specialists, 2 specialist registrars, and then we have a couple of other registrars doing their PhDs, a specialist physiotherapist, specialist occupational therapist, special dietitian, Leslie, specialist speech and language therapist I left out. That's because you left. Leslie's in the back, she's one of our Miranda people. There should be an SLT there as well, sorry. Specialist social worker, dietitian, a senior psychologist, an assistant psychologist, somebody to help us with the breathing, a genetic cancer, 2 data managers, and admin support. So that's all funded by the HSE. It's about 1.5 million per year the HSE is giving us to fund the national service. So it's really important. So what are we doing in the clinic? Well, we're trying to improve in the patient pathway. This is Miriam's work. Miriam has been looking at how long does it take to get to see a neurologist, and how long does it get to see the to get to the multidisciplinary clinic, and it's about 17 months, and we need to try and improve that by getting people to recognise the symptoms of the disease, so that you don't see 5 or 6 healthcare professionals before you get to see a neurologist, and another couple of months before you come over to our clinic. So that's really important. We're working hard on that as well. Our care is patient-centric and caregiver-centric, and Miriam has been helping us with that. So understand the experience of the disease beyond the disease. So we think about the disease, but the person with the condition has an illness, and the illness doesn't define them. It's about who they are, and this is a part of them that's interfering with their ability to live, and we're trying to help to make that a tolerable experience. Using people with the condition and the caregivers as collaborative partners, trying to understand clinical meaningfulness of treatments that we give, understanding, as Jonathan was saying, what people want, when what I think you want might be completely different from what somebody wants, and then thinking about new technologies. And this is some of the work that Miriam did before, showing that quality of life. People often say, oh God, I wouldn't like to just kill my quality of life. My quality of life would be deteriorated. But our experience is that if you don't measure quality of life by health, that people's quality of life can actually remain very good with the right support. So that's really important to recognise as well. And again, this is Miriam's work as well. And then understand the needs of caregivers, the burden, but also the benefits of caregivers. Miriam's done a lot of work more recently on the benefits. I think you're going to talk about the work from Scotland as well, and this Miriam has been helping with. So partnering with the person and the caregiver to understand their needs, and we have a system called TIM, which is telemedicine MND. So the coronavirus, we have to thank the coronavirus for that, because we got a grant from the HRB to build this telemedicine and MND service. It was designed originally by colleagues in Sheffield. And so we have this app on that we can give to people on their phones, and they can tell us how they're experiencing the condition. That can help us to define what's going to happen in the clinic. The last thing I'm going to talk about is the register. So the register, and then now the Precision ALS register, helps us to understand the disease. So we collect information in the clinic about the onset and the features of the condition. So the exam that I do, we do a small thinking behavioural screen. We take a family history. We ask people for a blood sample, and then in Precision ALS, we'll ask people would they mind taking a phone call from a young girl called Niamh Timon every 3 or 4 months, just to see how people are getting on. And we're going to incorporate that. We'll have about 2,000 new people enrolled in Precision ALS every year. We're hoping to have 6,000 or 8,000 by the end of 3 years. And we're also asking people to give us some blood samples. Some people will have an MRI, some people will have EEG, some people will allow us to test these new measuring devices, and some people already participate in that, and identify new ways of measuring change. So these are things that we're doing within Precision ALS. And I showed you that before. So to conclude, we are at the cutting edge. We've made many important discoveries. I had a slide with all discoveries, but the slide, there wasn't enough space in the slide for all our discoveries that we made over the years. We work very closely, as we should, with these very large centres across Europe. We're proud members and leaders in many of these areas, and together we're quite sure we will find new and more effective treatments. In the meantime, we're really grateful to all the people who've helped us over the years, the time, the generosity that people have given to allow us to invade their lives a little bit and tell us a little bit about what their disease is like and how it's progressing. So we're really grateful for people for allowing us to do that. And we're also incredibly grateful to the IMNDA for both the research support that they're giving us, but also the patient-centric and caregiver-centric support that defines the IMNDA. You know, I think I've worked in the voluntary sector all my life. I've been a consultant for 27 years, but I've had a consistent and long-term relationship with the IMNDA, and I can say hand of heart that it is one of the best voluntary organisations in the country, and it is a model and a beacon that other voluntary organisations should emulate. It's a fantastic organisation. This is our research team. The clinical team was very big as well. And here are the Miranda people here. So Leslie's in the background. Who's with you, Leslie? Okay, Chassous. Okay, Chassous. So that's Leslie, David, and Avril. So they're our fantastic Miranda people. So Leslie, some people would have remembered as a speech and language therapist in Beaumont. We really miss her, but we're getting a new one. Avril is and David are physiotherapists who are working as academics now, but we'll bring them back into the clinic then when they're finished their training and they become academic research oriented clinical professionals. So thank you very much for listening to me.
Thank you very much, Orla. And again, it is brilliant that you give the time to come here to speak to so many people who are watching online as well. And I'm going to go, before we open it up to the floor for questions, because I'm sure there will be, I'm just going to read some of the questions that have come in. First of all, it's a comment from Brian Purcell, who's watching us on the Zoom. Thank you, Brian. He say, I'd like to say how useful IMNDA is for me as an OT working in primary care, in the primary care centre. The service is hugely beneficial in the area of providing equipment and funding. Thank you for the service, so thank you for that. Riccardo and Claire are online from Italy, no less. They want to ask about an announcement in France on AMX0035. They are starting an early access programme with news on EU approval in the next week or so. Will Ireland have early access?
That's a bit premature.
Okay.
So that's the Phoenix study, and the Amylyx compound. It's maybe an offline conversation. Amylyx has gone to the EMA for what's called conditional approval of the compound. The EMA turned them down. They've got an appeal in, which will be decided in the next few weeks in the EMA. There may or may not be an early access program. That'll be country specific. It may require that people pay. We have a huge problem with early access programs in Ireland. If there were an early access program, it may not be possible to in Ireland. The chief pharmacist in Ireland is of the view that early access programs distort the market and that we should be pushing to get the drugs approved. So it's not straightforward. It's different for different countries. But we don't know if the drug works. We won't know till next March whether that drug works or not.
So we're watching brief.
That's Phoenix. Yeah. That's a Phoenix study. I understand what they're saying, though. But
Dennis Fitzgerald is with us as well on Zoom. He says he was diagnosed with MND 18 years ago. He's been taking Rilutech tablets since his diagnosis. He wants to know, is it still being prescribed for newly diagnosed MND patients, and is it recognised as a treatment of benefit for MND?
So riluzole has been around since 1994, actually, and it doesn't stop the disease, but every time we've looked at this, we've looked at 4 or 5 times, and actually, Precision LS, we've looked at it again. People who take riluzole always do better. So it is beneficial. The mechanism of action is probably not the way it was thought when it was designed, but it probably
like all best medicines.
It is effective. And all of the new treatments that we're doing, everybody is already stable on riluzole when we start the new trials. Okay. So yes, it is. And yes, it's still effective, and yes, we still prescribe it.
Brilliant stuff. Dennis, thank you very much for watching us on Zoom. Now, time to open it up to the floor. So if you have a question, if you'd like to just draw my attention to you, we've got another microphone at the back of the room as well. So yes, we're going to go to this gentleman and then come back to you as well. So if you wouldn't mind just saying your name, just for the people who can't see your name badge, if that's all right.
My name is Lionel Mackey. Professor, is there an increasing number of people per population with ALS or MND?
Yep. So it's a great question, and the answer is yes. So Rob McFarlane, who's a young physician who's a very scarily talented mathematician as well, has been looking at our register, and we have a paper just been published showing that there is a rise in incidence of motion neuron disease in Ireland. Now, part of that is because our population has increased. So it's really interesting, actually. He's done some really cool maths on this. It's very interesting. So our population has increased from when we started motor neuron disease research, which is back in 1994 with the register, population was 3.5 million, and it's now 5.5 million. So there is an increase, an absolute increase in numbers. When we started, there was 78 new patients per year, and now there's 140. So part of it is population rise. Doesn't account for it all. So there's still an increase that we have to think about. And it's very interesting, actually, because he's got another paper we've just submitted, which is called an age period cohort study. So it maybe, if we think of motor neuron disease as a gene environment risk, some of the environmental exposures may differ over the years, or the different cohorts might be exposed. So there's two take-homes from that. One is that we have a big hole in our population. If you look at the Irish demographics, between 1950 and 1964, we had net emigration. 1 in 5 people left the country during that period of time. So that would be the population that might have been at risk for developing motor neurones that disappeared out of Ireland and never came back. So that might have accounted for the slight increase that the next generation, now the people born in the 50s, are a bit more risk now. So they didn't emigrate because they were babies. So it may be that slightly lower rate in the population that we collected originally was people that hadn't emigrated, but we lost a whole part of the middle part of the population. So that's a possibility. The other thing is that there may have been exposures, very early life exposures, that might have made some people more at risk than others. And there's some intriguing data on that as well. Where maybe a period of intense deprivation may have increased the risk in childhood. So there's some data on that he has as well during the emergency in Ireland. We want to replicate that, for example, in the Netherlands. There was a famine after the Second World War. So it may be very early childhood exposures may have changed that. And then the third reason is that there's something called the Gesundheim effect. It's an epidemiological concept where if you live to a certain age, your risk of developing something goes up. So as we are better at managing cardiac disease, heart disease, and cancers, more people are surviving. So people who might have died from other diseases in their 50s and 60s are now surviving, and that they wouldn't have been there, but now they are. And then the final thing that he's shown, which is really interesting as well, is that the age of onset has moved slightly to the right as well. So in other words, the peak age of onset when we started was early 70s, moved on to mid 70s, and the mean age moved from 62 to 64. So that's a real effect. So people are healthier, and being healthier may protect a little bit from developing motor neuron disease. So it's a really interesting question. The answer is yes. The incidence is rising, and we're trying to understand from an epidemiologic point of view why that might be.
That was the most fascinating yes I've ever heard. I would have stopped at yes, personally, but fantastic. Okay, another question here.
Professor, I noted that the supplement TUDCA would be reported on at the end of this year. Are there any early indications of whether it's much use or not?
The answer is no, we don't know yet. So we're part of that study, so we'll get the first readout probably in end of November. And it'll be presented at the international meeting in Basel in December. So we don't know yet.
Sorry, Orla, could I ask you about environment and trauma? I just wonder about research around, for example, monomelic, which I declared interest. That's what I seem to have. And I'm just curious because it seems to be quite common in Japan and India. And is there any kind of recent research around that environment? And secondly, around trauma, for example, accidents that people might have at younger age. And, I mean, the genetic one obviously seems to be right up there, but I'm just interested in that myself.
So there have been some studies looking at trauma. The Euromotor study, we looked at trauma as well. We didn't see a very clear signal. Part of the problem is you'd have to look at the trauma from, say, -5 years from the onset of disease, because some of the falling after that, or the injuries that might happen, might be a function of an early manifestation of the disease. So there isn't a big signal epidemiologically of trauma as a risk. So we haven't been able to demonstrate that. There are some intriguing questions that you've raised around why one person might get monomelic disease and somebody else might get a much more rapid progression. And that's, we don't know the answer to that. It's a really good question as to why the disease doesn't spread in some people and does in others. We have some families where one family member might have monomelic and somebody else might have bulbar onset and somebody else might have limb onset. I know of one family where that's the case. And so we don't really know why that is. It's a really good question. And it's obviously some individual factors, because these would be cousins of one another. There is another really interesting hypothesis which has been proposed by colleagues in Germany, where if you had a previous brain insult or and you're at risk of developing motor neuron disease, the motor neuron disease might develop initially where that brain insult was. But they're single case reports. So it's an intriguing idea, but we don't know the answer. In terms of the population differences, there are definitely population differences. We don't know enough about MND or ALS in India. It's a massive country, and lots of different parts of India as well. So it's really interesting as to whether there probably is a different, what we call phenotype in India, in parts of India, but it needs to be studied properly. Japan, there are some population-based studies. I'm not aware that the phenotype is that much different in Japan, actually, but the rates are much lower. So the Asian genotype is protective for some reason.
Okay, brilliant stuff. Thank you very much for that. Now, Etna is bulling to go at the back of the room here. Absolutely bulling. So we'll go to the back of the room. You can say your name, please.
Hello, my name is Todd Nugent. I'm just wondering, is your research solely on ALS, or does it encompass the other forms of motor neuron disease?
Yeah, it's a good question as well. PLS and PMA. So PLS has been a difficult condition to study because it's rare. Peter Bede has a big grant to study PLS, and one of his PhD students, Owen Finnegan, who finished up recently, did some work on that. And there's about 50 or 60 people with PLS in Ireland, and there are initiatives underway now to collect those data into a larger international registry for PLS with a view to developing new treatments.
Can I ask a stupid question? What's the difference between P and ALS?
So PLS is primary lateral sclerosis. So motor neuron disease, when it was originally described, is a disease of the motor system. So the motor system is complicated. See, if the brain thinks about movement and there's a set of nerves that go down from the brain to the spinal cord, and then they talk to nerves that go from the spinal cord out into the muscle. The ones from the brain to the spinal cord are called upper motor neurons, and the ones from the spinal cord out to the muscle are called lower motor neurons. And most motor neurons, the ALS, is a condition where we can see problems in both of those nerves, the upper and the lower motor neuron. In PLS, it's only the upper motor neuron gives trouble, and in progressive muscular atrophy, it's only the lower motor neuron gives trouble. We don't have very many people with PMA in Ireland, actually. But we have about 50 or 60 with PLS.
So there is research ongoing, which is good. And it just goes to show that we have a good centre of research. I'm going to take two more because we do need to press on. Another question over here. Is it? Yep.
Good afternoon, Orla. You just touched there on environmental risks there. I think you spoke about one of your colleagues, James Rooney, was doing research. Would you just talk to us again about the pesticides and algae risks that environmental risks.
So I didn't quite...
Environmental risks such as pesticides, I think is the question.
So, I mean, environmental pesticides have been mooted as a risk for a number of neurodegenerative conditions, including Parkinson's, actually. And there may be a signal there, but it's weak. And most people who are exposed to pesticides don't get motor neuron disease, and many people get motor neuron disease are not exposed to pesticides. So it may be a risk on the background of a particular genetic susceptibility. We'll be able to answer some of those questions with precision ALS as well, I think, particularly from a genetic point of view. So I think at the moment the jury is still a little bit out on that. There is a group in Michigan in the US who've done some work. We published it in the journal suggesting pesticide exposure may be important, but I'm not sure I fully believe it either. Actually, I think it's really difficult, and I still think it's a gene-environment interaction. Okay,
I've just about enough time for one more quick one. So have we? Yep, Jez, you're flying down the back there. Once you got going, I'm telling you, the Sligo lady is proven to be very strong. Okay,
Thank you for everything. So far, it's very interesting. I'm lucky enough to be one of the young ones below the 60 line in getting the condition. So with all the studies that are being done, is there any more clarity into how can we look into kids, our children, to try to have an early detection?
So the question is, it's about a question about heritability, it's about your risk to your children. Yeah. So we've done some work on this, and we've just accepted. I just reviewed a paper for one of the genetics journals, and we've just accepted one for the journal I edit. So the good news is that if you have motor neuron disease, the lifetime risk of developing motor neuron disease for everybody is about 1 in 350. It's about 1 in 400 for women and about 1 in 300 for men. So it's about 1 in 350 is the lifetime risk for all of us, everybody. If you have a family member with motor neuron disease, your lifetime risk of developing motor neuron disease is about 1 in 299 or 1 in 300. It's not any higher, really. If you are a family member of somebody who carries one of the known genes, so you have a 1 in 2 chance of having inherited that gene from your parent, and if that parent has motor neuron disease, is 1 in 2 chance of inheriting the gene that is linked to your parent's motor neuron disease. But it's not a 100% probability to get the disease. It's much lower than that. And so it's really the genetics, even in familial motor neuron disease, where it's a single gene, it's much more complicated. And when I showed you the slide of the gene-environment interaction, and I said there's 3 to 5 steps, you get genetics 1, it goes down to 3 to 4, or 2 to 4 if you have a genetic form. So you still need more steps to get the disease. So getting the disease from a gene is called the penetrance. So the penetrance of motor neurons is actually, even with known genes, is actually quite low, and we need to understand why that is. We've been doing a lot of work, and some people here would be working with us on this, particularly on the C9orf gene, because it's the commonest gene in Ireland, talking to family members, and family members have very kindly given us a blood sample, and we've been able to check the blood sample in the lab. I don't know who has the gene or who doesn't, because I shouldn't, and I'm blinded because we can't tell the person, but our geneticists and our researchers would know that, but they wouldn't have met the people. And so we're very interested in family members who both carry the gene and don't carry the gene, to see if there's a particular signal. And there's a little bit of a signal in the people even who don't carry the gene. So it's really complicated. It's a very complicated process. But complicated is good, because it means that the risks are lower. If it's complicated, it means that it's not 100%. There are diseases, for example, neurological diseases. There's a disease called Huntington's disease, which is genetic. And if you have the gene, you get the disease, basically. That's it. But it's not the same in motor neuron disease.
You have enough to worry about in life. Don't let that be one of them.
Yeah.
All right, that's the easiest way.
Yeah, the bottom line is you don't need to worry. Thank you, Jonathan. Yeah. Thank you for paraphrasing what I was saying.
It's the PR training coming out. Ladies and gentlemen, Professor Orla Hardiman. Thank you, Orla.